All right, welcome everyone to today's webinar on time motion studies. We're going to be talking about some ways that public health departments can use this implementation science strategy. This webinar is being hosted by RAISE and NASTAD. RAISE is the Research Alliance and Implementation Science to End HIV Hub, which is a part of the University of Washington Fred Hutch Center for AIDS Research. And if you're not familiar with NASTAD, we are a national nonprofit association of public health officials from mostly state, but also local health department HIV and hepatitis programs. This is an NIH-funded initiative, and the goal of the hub is to advance implementation of EHE activities by promoting evidence-based interventions, supporting EHE-funded implementation research projects, connecting health departments with researchers to respond to health department needs, and also providing technical assistance to EHE Phase 1 jurisdictions. You can learn more about our work together on the NASTAD website as well as the RAISE website. And we will also put a link in the chat where you can fill out a consultation form if you're interested in learning more and talking with the team about how we can support your implementation science activities. So today's talk is going to be given by Monisha Sharma, who is the Assistant Professor of Global Health, as well as the Adjunct Assistant Professor for Epidemiology at the University of Washington. She's the principal, her research interests include mathematical modeling and cost-effectiveness analyses of HIV testing and linkage to care interventions in sub-Saharan Africa. And she's also currently working on a scale-up project of assisted partner notification services in Kenya and collaborates with the Institute for Disease Modeling to project the impact of scaling up point-of-care viral load monitoring for patients on ART in sub-Saharan Africa. So I will pass it over to Dr. Sharma for our presentation for today.
Great, thanks, Krupa, for that introduction. I'm just going to share my screen. Okay, can you see my screen?
Yes, we can.
Perfect, thanks. So today I'm going to talk about time and motion observation as it kind of relates to economic evaluation. So I wanted to start by defining economic evaluation. So an economic evaluation is an analysis that considers both the comparative costs associated with two or more health interventions and also the comparative health effects. So you're comparing the costs and the health outcomes of different interventions to assess their value. And the overall goal of health economics is to distribute limited resources in a way that optimizes population-level health. So basically, we have a limited amount of resources, and we want to figure out the best way to distribute them to maximize health outcomes. And economic evaluations are a way to synthesize all of the available evidence, and this includes costs, intervention effectiveness, disease burden, etc., to provide an estimate of value for money of an intervention. So this graph here shows the life expectancy on the y-axis of several different countries, mostly high-income countries, and the amount they spend on health per person on the x-axis. And you can see that the US is an outlier in red, so it spends a lot of money on healthcare, but the life expectancy is much lower. And this really highlights that more expensive doesn't lead to better outcomes necessarily, and it's really about explicitly optimizing the way that that money is spent. So one of the most common cost effectiveness economic evaluations are cost effectiveness analyses. And we can assess the cost effectiveness of an intervention by calculating the incremental cost effectiveness ratio, or ICER, which is a ratio of the difference in the costs of an intervention minus the cost of the standard of care over the difference of the effectiveness of the intervention minus the standard of care. So essentially, it's the difference in cost over the difference in effectiveness. And if your ICER is below some threshold that you're willing to pay, you would consider that intervention cost effective. So most of the health economics literature focuses on cost effectiveness analysis, and they're useful for identifying interventions that provide good value for money, but they don't provide much information on affordability. So an intervention might be cost effective, but if it's not affordable within the healthcare budget, then you're not able to implement it. So budget impact analyses are another type of economic evaluation that's a complement to CEAs, and they provide different information, and they estimate the financial stream of consequences of implementing a new intervention. And this is useful for budget planning, forecasting, and determining affordability of an intervention. And so BIAs incorporate the cost of the intervention as well as any costs averted. So if you're implementing a HIV testing and treatment intervention, you likely are averting hospitalization costs associated with persons with HIV who are out of care. And so when you're designing your economic evaluation and also your subsequent time and motion observations, one of the first steps is to decide which perspective to use. So if you take, and the perspective is the point of view of that you're using when you conduct the evaluation. So if you take the payer perspective, only the costs and the time that are allocated from the organization implementing the intervention would be included. For example, this could be the Ministry of Health or a private insurance company, the government. And if you take the wider societal perspective, then all of the costs incurred are included or saved, regardless of who experiences them. So this includes patient time and childcare and lost wages. So if you're doing a time and motion, you would estimate the time that it takes for a patient to receive an intervention, the time that they're waiting in the waiting room to get care. And the perspective that you choose will depend on who's using the economic evaluation. So often, private insurance companies are interested in just the cost incurred by their company, but governments are often interested in the costs incurred by society as a whole. And so the cost included in an economic evaluation make up the numerator of the incremental cost effectiveness ratio. So these are all of the change in costs, the resource use, the costs averted by averting disease, and then the denominator is the change in health benefits. So this could be measured in life years adjusted for quality of that life, so QALYs or DALYs. So in order to assess costs, we first identify the resources used in an evaluation or an intervention, and then quantify those. And that's where the time and motion comes in, how much staff time is used for an intervention, along with how many supplies are used. And then we value those. So the staff time used times the salary of that staff would give you a time cost. And multiplying the unit cost by the quantity used will get us the total cost of the intervention. So there's several approaches for measuring costs, and they range from more precise, so microcosting, where you quantify every input that's used in an intervention. That's the most precise, but it's also the most resource intensive. And then on the other side of the spectrum, we have gross costing, which we just take the total cost of the budget and then divide it by the number of people seen. And then we just get a lump sum of, cost per person served, cost per clinic visit. And in general, we conduct a mix of these approaches. So we don't microcost every aspect, but maybe the aspects that we care the most about. And in microcosting, when we collect costs either from a randomized clinical trial or an observation of a program implementation of an intervention, we can use this to estimate the resources and assign cost to those resources. So we often split costs into mutually exclusive categories. So here are just some examples: personnel, vehicles, equipment. So then you can then more easily define the costs that are associated with each of these categories. And one common type of microcosting is activity-based microcosting. So here you can microcost a set of program activities. So the first step is to divide the intervention into activities, which makes costing easier, and then identify and measure the time and resources used. And for example, this could be some resources used or some activities associated with an intervention. And creating an intervention flow map can also make things easier to make sure you've identified all of the categories. So for example, we had an intervention of adolescent HIV care in Kenya. So we created a flow map of a patient going through the clinic. So the patient enters, checks in, goes to triage, and then so on. And then you have kind of a sense of everything that happens, and you can identify the resources used in each of these portions of activities. So as a part of microcosting, we do time and motion observations and also staff interviews to supplement the time and motion observations. And that's kind of what I wanted to focus on today. So a time and motion observation is an analysis of the time spent in the different motions of a job. And this was originally used in systems engineering and industry to optimize workflow and identify inefficiencies. So for example, you could conduct a time and motion of a process and decide that people are spending or workers are spending a lot of time filling out paper forms, and you could replace them with electronic forms that are easier and quicker, and you could optimize the workflow. You can also remove bottlenecks. So if there's not enough people working on one task and things kind of pile up, you can change your hiring so that everything is more streamlined. You can also evaluate employee productivity and estimate the number of staff needed for different tasks. So the time part is just how long a task takes, and then the physical activity that's happening is the motion part of the study. And so in healthcare, we can use time and motion observation to quantify the impact of a health intervention on staff workflow and patient experience. So when you add something new to a health system, there are impacts to other things that the staff might be doing, and some of these might be difficult to quantify beforehand. So you kind of want to understand the flow of a certain intervention and how it impacts the other activities that a provider might be doing. So there are several ways to do time and motion observation. The most common is that an external observer will watch and record the time needed for intervention activities. And then this data is used to estimate the staff time costs needed for that activity. And this is a literature review of different time and motion data collection methods in the literature. And you can see the most common, so 42% are external observation, doing continuous observation. So continuous observation of individuals doing their job is the most accurate form of time and motion. It's less burdensome than self-report. And it's a really good way to get a sense of the workflow without asking workers to interrupt their workflow by recording what they're doing. But there are also methods including self-report, so activity tracking. So a worker will fill out a log of when they start and stop different activities, and you can analyze that data. You can also do surveys, interviews, asking participants, providers, how long they spend on different aspects of their job. There's also automated ways to record time and motion observations. So sometimes when you log in and out of a system to do a patient medical history, it'll log in the time you started and stopped in activity. If there's usually, if you have to drive out somewhere to deliver an intervention, sometimes you have to log in and out anyway of your workplace, and you can use those records to estimate time used for that activity. So often there's a combination of methods used, and generally in my work, I've used a combination of methods. So continuous observation is one of the main ways that I've estimated that the time an intervention takes, but also supplemented by staff interviews and potentially activity logs if people are already logging, or if the system is already logging different activities associated with an intervention. So you can use time and motion studies to estimate healthcare provider time administering an intervention, and also participant time spent waiting and receiving care. And if you're looking at costs from a societal perspective, you'll want to also conduct time and motion of the patient. And we can also use time and motion to remove any research costs. So anything associated with administering the intervention from a research perspective that wouldn't be there if it were a program, you can identify and remove. So the steps for conducting a time and motion in observation is first to divide the intervention into activities. So for example, if you're looking at a PrEP intervention, you can divide that intervention into clinic visits for PrEP initiation, follow-up visits, lab processing, etc. And then you divide each activity into parts. So if you took the clinic visit for PrEP initiation, you could divide that into parts. Like first, the provider conducts an HIV test to make sure that that person is negative. Then they do a risk assessment to determine PrEP eligibility, then provide counseling, and then the PrEP prescription. And then you can time each part. And then we try to observe multiple activities of the same type to get the mean and the variability across staff members and time in terms of completing that activity. And so if you were to have a, if you were doing a time and motion as part of a randomized clinical trial, your steps or activities within a clinic visit for PrEP initiation might look like this. And so here you have informed consent and a demographics questionnaire, because you're conducting research on who initiates and continues PrEP by their demographics. And then perhaps because it's a RCT, there's a reimbursement of the participant. So those are all research time that if this intervention was going to be implemented as a program, those wouldn't exist. So you generally time and remove the research time from the total activity time. And then you often, when you're costing in a RCT, you often want to know how the intervention itself might be administered differently if it were outside of a clinical trial setting. So perhaps if it were implemented by the Ministry of Health, there might be a shorter risk assessment tool, or perhaps PrEP prescription dispensing would be 3 months. Every 3 months you'd have to come back, instead of the study got an exemption and provided PrEP every 6 months. So in that case, you would shorten the time for risk assessment and then assume more follow-up visits. So when you're estimating the time that it would take for this particular activity, because you've observed every portion of it, you can really refine and change scenarios and say, well, what would happen if I took this part out? Or what would happen if this happened at a different time? And you can kind of optimize the workflow, but also get a good sense of how things might change if they were implemented in different scenarios. Another thing we try to do with time and motion that you can't do if you're just, asking someone to give you the time it takes to do an activity, is that we can only assess the active time associated with that activity. So for example, if you had lab-based viral load processing, there may be centrifuging a specimen, placing it into a cartridge, and then running the viral load machine, etc. And let's say, just for as an example, perhaps running the viral load machine takes 15 minutes, but the lab tech isn't standing there for 15 minutes just waiting for the machine to run. They're doing other tasks. They're doing something completely unrelated to this viral load test. So we don't want to count the lab tech time where it's not actively associated with this particular activity. So only the time that they're actively loading the viral load machine, and then when they come back to continue processing it, that would be the active time associated with this this particular activity. And then again, because you're doing this observation, you have the ability to take out those kind of idle times, or those times where somebody is doing something else. And so there's a lot of caveats associated with conducting time and motion observations. So for example, there's a lot of multitasking that goes on within all of our jobs. And so sometimes it's hard to estimate the time associated with one particular subtask in in a whole kind of stream of workflow. So for example, often when we've observed HIV testing, we are estimating pre-test counseling, HIV test, and then counseling. But some of these happen at the same time. So as a counselor is conducting the HIV test and drawing blood, they're also doing the pre-test counseling. So we can't really separate those two activities together. So we kind of have a time that's just associated with both of those. There's also task fragmentation. So if somebody starts to work on something and then stops and starts to work on something else, you can pause and then start that new task and then go back when the person goes back to the original task. And then there's also interruptions. So sometimes a provider is serving a client and then something else comes up and they leave to go deal with that other thing and then come back. You can remove that time from the time it takes to complete that specific activity. And there's also just real world variability in workflow. So there are things that you that will just be different across providers, across work styles, that you will just end up kind of with a rough approximation of how long a task takes, because different people are going to do it differently in different clinics, and places are going to do it differently. There are some ways to calculate inter-observer reliability that's becoming more common in the literature that you could also decide to do as well. So time and motion observation is also a good time, if it's being done as part of a microcosting, to just make a note of the supplies used in each activity. Because in addition to the staff time, you really want to know what are the resources that go into each of these activities. And so as you're watching somebody collect blood for a viral load draw, you could write down everything that the person is using and have a list here. And so for each activity, you can say, 5 minutes blood draw, and these are all of the supplies that they're using. And that's a good way to get a kind of a comprehensive understanding of the resources required for that activity. So in terms of sample size for a time and motion study, there's really not a set number. It's similar to qualitative data collection, where you just keep observing a task until you feel like you've hit saturation. So you really have a sense of how long this takes, and watching more observations is not going to give you more data. You sort of feel like you have it, and then that could change. It can vary by activity. There's certain activities, maybe like a blood draw, that's very standard. After watching 3 or 4, you can say, I know how this goes. But then adherence counseling, there might be more variability. So you might have to do more observations before you reach that kind of saturation point. And you generally also want to vary the staff that you're following. So across the program, you want to try to follow each of the staff if possible, because everyone has inherent differences in how they do their work. Vary the days observed, potentially the season. So maybe activities go faster in the morning, or on certain days when the clinic is busier, it's slower during the holiday season. And so in order to get a mean time, you kind of want to capture all the variation and then the time spent in each kind of subset of seasons. So you can organize your time and motion results into Excel, which is what I normally use, and then you calculate the average and standard deviation time for each activity. So here is one observation for a PrEP telehealth intervention. And so we have here each of the activities within within the consultation, and then you have the total time, and you would have a series of 10 or 15 of these observations, and then you can summarize them with a mean and a standard deviation. And you can use these findings to inform productivity assumptions and then staff structure. So based on the time needed to complete all of the intervention activities, you can estimate the number of staff that you would need to reach a certain volume of clients. Or the inverse, you can estimate the number of participants you can see given the size of the staff that you have. And you do that by estimating how many participants one staff member can serve per day, kind of accounting for the days worked. And so I also wanted to put in some practical tips, because a time and motion can be kind of an awkward thing to do. You're following around people with a stopwatch and writing down what they do at work. They might feel like they want to change their behavior if they're being watched, and that's called the Hawthorne effect, where they might work more quickly or take fewer breaks. So it's really important to talk to the staff and let them know that you're not evaluating their workplace performance. You're not going to report it to their supervisors. You're trying to assess the resources needed for an intervention. I personally often collect data on a notebook instead of a computer, especially for community interventions outside the clinic. It just looks less conspicuous. And then you can have a discrete stopwatch. And then kind of try to stay in the background. So you introduce yourself, get to know the staff, and then just kind of like sit in the corner and try to write down and measure what you see. And hopefully people will kind of forget that you're there. It's also helpful to think about the timing of data collection. So often we collect time and motion data after staff are trained to do an intervention and they're operating kind of at peak efficiency. But it might also be good to, as we mentioned, collect observations during the year where there might be variation, like seasonality, or if there's a startup period where there's a lot of training, you might want to time how long it takes to actually do some of the training associated with an intervention. And so this is an example of time and motion results from the published literature from a rural clinic in Malawi. And here, these results are split up by patient type. So we have adults and children and their average time spent waiting at their clinic and their average contact time. So that means the time that they're spending with a healthcare provider, and then the total time. And you can see most of their time is spent waiting to see a provider. And so in addition to capturing the average time and motion results, in this case, it was helpful to capture the variation over the days of the week and the times of the day. So we can see that Tuesdays and Wednesdays seem to be the least busy. So there's the lowest waiting time. And then later in the week, the clinic becomes more busy. So Thursday and Friday have longer waiting times. And there's also variation by time of day. So people spend more time waiting in the morning and less time later on. And this is generally because people are getting there before the clinic opens and are spending time waiting to see a provider. So there's many different ways to collect time and motion data. There's simple kind of word-based documentation tools. So this is a PrEP study in Kenya, and this is the client time and activity tracking form. So it's really open-ended, just writing down activity, time start, time stop. And this you can fill out by hand. So you can collect time and motion data just in a notebook, or you can collect it in a pre-specified activity form, such as this, Excel or Access, REDCap. There's recently more and more mobile applications that I've seen kind of students use to just more sophisticated ways to track different processes, and then they do data visualization of all the different activities. And so there's a multiple different methods. Eventually, you'll want all of this data to be in either Excel or R, so you can get that mean and variation of time. So whatever makes the most sense, is the most discrete, is probably a good way to go. And this is another data collection tool. So Here is another prep trial, and it's, you know, each activity of the participant approaching the pharmacy, trying to access prep. There's one activity which is an interruption where the pharmacy staff leaves to help another patient, so you can put that into the form as well. And you can also add columns to this. So in addition to the time, you can say a column for the resources used or the staff involved. And so you can, you know, do blood draw and then write down all the resources used for that task. And then this is another access time and motion form. And often you can, as a time and motion observer, you can write down, you know, pre-test counseling, HIV test, and post-test counseling, and kind of write down your own kind of activity codes. You can also create pre-specified activity codes. So here in this paper, they used these task codes, so A, B, C, D, all the way down to K, and the observer would fill in these pre-specified codes into their observations. And there's, I think, what a lot of times when you train someone to do time and motion, some people might write much more details. They might say, you know, this type of counseling, then they ask that, and they can get really, really detailed in terms of what's going on. But we really just want the right amount of detail, just like a higher level pre-test counseling and then the time. And so, but if somebody does make it more detailed, you can always combine those later on and create the categories that you want. So you do have that flexibility. So from the time and motion observations, we can calculate the costs by calculating the cost per minute of each staff based on a 7-hour workday, accounting for holidays and sick leave, and then their salary and their benefit information. So this is in Kenyan shillings, but these are different staff members that are spending time on this intervention, and the duration of time that they're spending and their salary. And you can go through and multiply the minutes spent times their salary to get a total cost. So time and motion provides an assessment of how costs are distributed across a program. And this allows you to identify cost drivers and areas of inefficiency. And this is different from gross costing. If you just have the total cost and the number of people, you can just say it costs X amount for a clinic visit, but you can't say personnel are the largest cost driver or supplies, and you're not really able to change around the scenarios to look at different ways that the program could be implemented. It also allows you to assess what happens when inputs are changed. And you really often need to conduct time and motion observation if you are doing a clinical trial or anything that would be implemented differently in a real world setting, because you want to remove all the time costs associated with research and other data collection. It's also, some of the cons is that it's resource intensive, and it often underestimates total cost. So if you just take the total cost and divide it by the number of people seen, that's the cost, but you're usually missing something, no matter how kind of detail-oriented you've been. So I wanted to quickly go through an example of using time and motion, and this is from an assisted partner notification services intervention in Kenya. And our research question was, is active partner notification for HIV cost effective in Kenya? And so partner services are, as most of you know, is to identify sex partners of persons diagnosed with HIV, notify them of their potential exposure, and then provide testing and referral. So in this case, there were two arms. The passive referral, which was newly diagnosed index clients, were just asked to notify their partners. And then APS, where healthcare providers directly notified partners. And so our plan here was to conduct a microcosting of a trial that was ongoing. And here I traveled to Kenya to do the time and motion, but you can also train RAs that are in country to collect time and motion data. And then these costs were ultimately used for a cost effectiveness analysis. And so as I mentioned, there were two arms of the APS study. And some of the advantages of prospectively costing a trial is that you can get detailed costs that are not normally recorded, and then you can do time and motion. And then you get a firsthand kind of assessment of trial quality. And some of the cons are that an efficacy from an RCT may not translate to real world effectiveness, and you can also cost a study that turns out to not be effective. So here we conducted time and motion observation to assess time spent on intervention activities and also remove the research cost, and then assess how this would be different if it were being implemented by the Ministry of Health. And so in terms of interviewing staff, so a lot of times when we do a time and motion observation, we supplement it by staff interviews and we triangulate that information. So making sure that what we're observing is the same thing as what staff are telling us is happening. And if there is a disconnect, trying to interrogate that further and find out where some of the discrepancies are. So just asking a lot of open-ended questions and then trying to assess the variation in responses across staff. And then asking how it would be different outside of the setting that you're observing. So in this case, home visits, because it's an RCT, were done in randomized order, but actually staff would batch these visits and they would be much more efficiently done. So another thing to keep in mind with time and motion is it doesn't, your time to do something doesn't linearly scale across the day. So just because you can do one HIV test in 30 minutes doesn't mean that you can see 14 patients a day. There's burnout, there's demand, there's actually kind of breaks and idle time that you might need. So in addition to taking the time and motion to inform productivity estimates, you should also interview staff and ask them about what they think the maximum is that they can do per day. And then again, asking about seasonal variation, for example, rainy seasons. And we also did some societal costing. So here we wanted to understand the time it takes. And so first adjusting the costs from the interviews and the cost that we observed. And as we mentioned, assessing variation and seasonal variation. So based on the time and motion, we estimated that administering APS takes about 40 minutes per partner reached. And so after accounting for staff time, for index participant screening, tracing, traveling to people's homes, and then other paperwork, we estimated that staff members can test 2 partners per day. And so the total cost of the program was the cost that we estimated divided by the program volume. So the number of partners that we estimated could be tested with the staff structure that we have. We also did some time and motion of patients waiting and receiving the intervention. And this can be combined with their travel time and their travel costs to estimate the costs, the societal costs of the intervention. So you can use an average daily wage rate in the country to estimate societal costs associated with different interventions. And sometimes these can be substantial. So people can wait a long time for care in one scenario and much less in another. And so even from the payer perspective, the cost could be the same. Looking at it from the participant perspective, it could be quite different. So we combined all this data to estimate the cost per person tested for HIV. And you can see in the blue that the personnel costs were the greatest. And so that's another reason it was really important to do time and motion observation to really try to accurately estimate those personnel costs. We also looked at a scenario of task shifting, and because the personnel was the greatest amount of percentage-wise of the intervention, when we task shift to community health workers, it would be a much more affordable intervention. You can also create other scenarios, varying client volume, various aspects of workflow, and then see how that changes both the time and the total costs. Okay, so some of the variables that might create, that affect costs and time and motion observation are the geography and the population receiving the intervention. So if you are in a certain area where the population might need more outreach, that might change the actual costs and the time it takes to administer an intervention. the HIV prevalence, so that affects the client volume, and also in this intervention, it costs more to reach an HIV positive versus negative partner because there's more counseling and there's more supplies with the confirmatory testing. The level of training of staff. So if you measure the time in motion in one area and try to generalize it to other kind of locations, there might be different qualifications that the staff have. The willingness of the population to receive the intervention, and then other variability associated with personnel themselves. So some personnel will just spend more time providing counseling, and that will just be an inherent variability. And so it helps to conduct sensitivity analysis around these assumptions, just to make sure that you understand the impact of these assumptions on your findings. So you can vary the number of participants that a healthcare provider can see per day, the effectiveness of the intervention, and then you can identify the most influential assumptions. So I think I'm going to stop there and see if there's any questions.
Thank you so much for that presentation, Monisha. We're going to open it up for questions now. You can raise your hand and come off mute. You can write in the chat. You can write in the Q&A. We're open to any questions you all have.
Great. So I see the first question for task sharing. Did we factor in the change of effectiveness when an intervention is administered by different cadre of provider? And that's a great question. So when you task shift from someone that's really high, maybe a higher level of training, that the effectiveness of the intervention may decrease. So we did in this case, we assumed a 25% lower effectiveness of the intervention, and then accounting for that, it was still it was still lower cost than using the higher cadre workers.
We have quite a few hands raised. I believe Sarah was first, followed by Akash.
Great. Thank you so much. Yeah, that was a really wonderful talk. I really enjoyed it. I actually had two quick questions. One of them was related to this estimation of costs associated with time spent doing the activity, and how, or if you had to anticipate, whether or not this was a true opportunity cost. So, for example, if a healthcare worker is not really working at full capacity, how much does it matter whether or not you're pulling them off of a different task versus, this is something that is an expected part of their, sort of job. So just curious how you try and account for that.
Yeah, that's a great question. So in this case, we kind of assume that people are hired for this position, or that they would be working on other things, and then this would be the true opportunity cost. In other areas where people have more idle time, and adding something to their list of tasks won't change the amount of hours they're working, then that would impact the actual true cost of the program. So what we generally either try to cost is the economic cost. So the economic cost would be that cost of the person spending time on this intervention, and the financial cost might be different. So if that person doesn't have enough tasks to do, then the financial cost would be zero. And so you do have both of those. And here I showed how these results are used in a cost effectiveness analysis. And in cost effectiveness analysis, you generally use economic costs. But if you were using a budget impact analysis and you want to assess affordability, then you would care about these financial costs. So even though a person is spending X amount of hours on something, if the counterfactual is that they just didn't have much to do, then you would factor that into your budget impact analysis. So it does depend on the type of analysis that you want to do.
Okay, great. I'll save my next question, let everyone else ask around, and if there's still time, I'll ask my second question. Thanks so much.
Yeah, thanks.
Thanks, Monisha, for a great presentation. So just a question based on reading prior literature on time and motion. Do you think a lot of times we might underestimate, like sometimes, you might have staff who take a lot of administrative tasks home. They're not able to, uh, finish tasks at the hospital, or at the clinic, and like it's a lot of paperwork. They just take it home, or there could be other hidden costs, which of course a directed observation isn't able to capture as well. So how do you account for that? Is it through, like, self-reported time again, comparing with, how much the staff feels they're actually putting in time, or are there other methods to account for this, or is it just a general limitation in the field?
Yeah, no, that's a good question. So that can be sometimes triangulated with staff interviews. So what you're observing is basically what you can account for, but if there's other tasks that you're not seeing, or that they're doing in another place and you're not accounting for that, then that's could be a missing cost. So you can try to get at that with staff interviews to see if they're doing some of the implementation elsewhere or doing work at home. So that would be important to ask them. And then if you do, you might have to ask them to estimate the amount of time they're spending. And this might kind of relate to Sarah's question, where if they're doing it at home unpaid, then it doesn't hit the financial stream. So if you're doing a budget impact analysis, it may be less relevant. But if you're doing a cost effectiveness analysis and you want to capture all the true economic costs, then you would probably want to factor that in. Anjali?
Thanks, Monisha. That was a fantastic webinar. I really, really appreciated it. I had a question about what you have kind of observed generally about people's appetite for the detail, like the level of detail that you would see in a manuscript. And I was, reflecting on that table that you showed that showed the stratification between peds and adults, different times of day, days of the week. Like those are so critical when people arrive at a clinic. And I wonder, in a big manuscript where you're ultimately doing something like cost effectiveness, where that level of detail is probably less relevant. Like what do people want to see, and where have you found a home for that nuanced, rich, detailed information that might not be critical to the big picture takeaways? Thanks.
Yeah, so a lot of this work really informs like specifically a clinic operation. So a lot of time and motion observation and budget impact isn't very generalizable outside the specific budget that you're looking at, outside the clinic that you're looking at. So a lot of times this can be used to optimize clinic flow and understand how clinics are running. And since there's a shortage of healthcare providers in many areas, trying to figure out how people are working and how to make it easier for them to be more efficient is important. But in terms of like high impact, it's not going to be interesting to publish. It'll be really interesting to the hospital management and to potentially like the clinic, but it doesn't generalize very well. So just because you're seeing something at one clinic doesn't mean it's going to be at another clinic. And I think it's useful to publish at least kind of high level findings in terms of an economic analysis, but a lot of these details do get lost when you're publishing something. I have seen published estimates, kind of like the one I showed, of just time and motion observation. So you could, in addition to doing your economic evaluation, just publish the clinic flow and time needed. And I have worked with a few students that have done that. So mapping out the clinic flow in South Africa and how patients, drawing a picture of like where all the patients go and how long they spend and what can be adapted. And has been an interesting contribution, I think, to the literature in terms of utility. So I think I would encourage people to maybe consider trying to publish their time and motion in detail separately, because I do think it's important, and it's definitely useful to the clinic, even if you don't kind of publish it to the literature as a whole.
Monisha, there are two other questions in the chat. Can you see them, or do you want me to read them out?
So I see Ariana's question about sample size, and so generally we don't really have good sample size estimates for time and motion observation. It's sort of, as I mentioned, like qualitative assessments. So just kind of continuing to observe until you reach a saturation of information where you feel like I understand how long this takes, I can move on. Is sort of what we do, and we try to capture all the variability across providers, across days, and it ends up being a rough estimate. It's not very similar to like epi, a lot of us come from like a scientific background where the more you measure, the more accurate your estimates get and the more precise, but there's just so much variability associated with this that you're never really going to get super precise. And so at some point you just kind of have enough observations and move forward. So the other question about stepped wedge designs. Yeah, I haven't actually used time and motion in step wedge designs, but I would kind of it would be usually with when you're looking at the intervention effect of something and you have a control period or a control and an intervention, you want to time both. And so the difference in that is the time that it takes for the intervention. So that's why, like with partner notification services, we want to have those two arms. And so in this case, you would probably want to time the control period and then see what happens differently at the intervention period, and probably when the intervention is running at more peak efficiency, not when people are still trying to figure out what the intervention is, but after a while, when people get into their rhythm, you can get a sense of how long it takes to conduct different aspects of the intervention. And you can also supplement that with staff interviews. And if it's the same staff pre and post, you can get a sense of how adding on this intervention has impacted their workflow and their experience of it. And yes, secular trends are just kind of inherent with the with step wedge design. So probably doing some staff interviews and understanding some of the cyclical variations in the clinic, and trying to adapt your estimates using that. So if your control period is in the summer and your intervention period is in the winter and there's a natural lull for holidays, you'll probably have to make some assumptions about how that would look different throughout the year. So there's a ton of assumptions that go into this because you're watching something at one point in time and you're generalizing it to the whole year, you're generalizing potentially across clinics. So there's a lot of kind of making educated guesses as to how this would change outside of the setting that you've seen.
We have a few more minutes if anyone else has a final question. Otherwise, we can wrap up for today.
There's one more question that was a direct message that says, what are other methods of evaluating efficiency? Because we at healthcare departments don't have time always to do a time and motion. And so that's a good question. It takes a lot of time and a lot of effort to conduct time and motion observations. And if you don't have that time, some of the other like self-reported logs or automated time collection or just staff interviews might be a good way to kind of supplement and understand the workflow associated with different aspects of an intervention.
Great. Well, thank you so much to Monisha for this exciting talk and rich discussion. Krupa, do you have any final words before we close out?
I just want to say thank you. Thank you to Monisha. Thank you to all our participants for your wonderful questions. Please do reach out to us if you have any questions or would like to request TA. Sorry, I'm trying to share my screen. Give me 1 second. Here's our email address if you have any questions, and we can also put that in the chat. Feel free to fill out the consultation form if you would like to request a consultation for your EHE jurisdiction on how you can utilize implementation science strategies for your EHE activities. And we will reconvene on November 20th for our next webinar. So stay tuned. We'll be sending out more information on the NASTAD listserv as well as the RAISE listserv for that. So thank you all so much. Have a great rest of your day.